Hey, what is up you guys, and welcome to Jane's Medical SBAs. Today we're going to go through the answers to all three parts of SBA question 2. Okay, let's have a look at the first part of the question. A 30-year-old female presents with nausea, fatigue and feeling short of breath. She has a known diagnosis of idiopathic intracranial hypertension for which she is currently undergoing treatment. An ABG is done and the following results are noted. Her pH is 7.3, her PCO2 is 4.0 and her bicarbonate is 15. The anion gap has been calculated and is also 15. Which of the following is the best description of this arterial blood gas picture? A. Normochloremic respiratory acidosis. B. Hyperchloremic metabolic acidosis. C. Normochloremic respiratory alkalosis. D. Hypochloremic metabolic acidosis. Or E. Normochloremic metabolic alkalosis. Now, before we answer this question, let's quickly have a look at acid-base balance. Now, this is the simple acid-base equation that you've probably already seen before, and that is that carbon dioxide dissolves in plasma and water to produce carbonic acid, which in turn dissociates to make alkaline bicarbonate ions and acidic protons. Now, this system works to regulate our blood pH, which should be kept between 7.35 and 7.45. Now, there are already plenty of videos out there covering this in much depth, so if you want to go ahead and check them out, please do. But I'm going to explain it in really simple terms right here. Now, because carbon dioxide dissolves to make carbonic acid, we can think of it as acidic, and the bicarbonate ions are of course alkaline. Carbon dioxide is normally regulated by our lungs through our breathing, and the bicarbonate ions are normally regulated by our kidneys through excretion or retention. Now let's just extract those two components. Now, if the blood pH is more acidic than normal, this is either due to an increase in the more acidic carbon dioxide or a decrease in the more alkaline bicarbonate ions. However, if the blood pH is more alkaline than normal, this is either due to a decrease in the more acidic carbon dioxide or an increase in the more alkaline bicarbonate ions. Now, let's go back to the question real quick. The first thing to look at when interpreting a blood gas like this is to determine whether there's an acidosis or an alkalosis. Now, looking at her pH, it's lower than normal, so there's an acidosis. This means we can rule out these answers here, and we also know that one of these three other things is happening. Now that we know that there's an acidemia, how do we know if carbon dioxide or bicarbonate dysregulation is responsible for it? In other words, how do we know if there's a respiratory or a metabolic cause? Well, if the acidemia was due to the bicarbonate levels being low, in other words, metabolic acidosis because your kidneys are excreting the bicarbonate ion or you're losing it through your gastrointestinal tract and diarrhea, etc., then you would expect to see a compensatory decrease in the more acidic carbon dioxide to bring the blood pH back up. And this is known as a metabolic acidosis. However, if the acidemia was due to the carbon dioxide itself being high, in other words, a respiratory acidosis, because you're retaining carbon dioxide by hypoventilating, for example, you would expect to see a compensatory increase in the more alkaline bicarbonate ions, again to bring the blood pH back up. Now, back to the question. As we can see, this patient has a low level of bicarbonate ion and a low level of PCO2. This is looking more like this picture of metabolic acidosis. So, we're almost at the answer, but what is the anion gap? Now, the anion gap is the measured difference between positive and negative ions, and that is sodium plus or minus potassium. You don't always need potassium, you can do it with just sodium, minus chloride and bicarbonate ions. This is used to help determine the source of the metabolic acidosis. That is an acidosis due to the dysregulation of bicarbonate ion. Now, if you're losing bicarbonate ion because you're excreting it through your kidneys or you're losing it through your GI tract and diarrhea, then your level of bicarbonate ion will go down. However, the negative chloride ions go up to compensate. As a result, this side remains normal, and so the anion gap itself remains within its normal range. However, if you're losing bicarbonate ion, not by physically excreting it from your body, but because it's being used to mop up excessive acidic protons from extra acid that shouldn't be in your blood, for example in diabetic ketoacidosis, then you lose bicarbonate ion from this equation, as the alkaline bicarbonate ions associate with the acidic protons to mop them up. But this time there is no compensatory rise in the negative chloride ion, and so this side of the equation will go down, and so the anion gap itself increases. Now, back to the question. So the patient has a normal anion gap, so this suggests that her levels of chloride ion have gone up to compensate for the decrease in bicarbonate ion. So she therefore has a hyperchloremic metabolic acidosis. Amazing, that's SBA 2 part 1. Now, before we move on to the other parts of the question, we didn't actually discuss metabolic or respiratory alkalosis. Let's go through that real quick. So, if the blood pH is greater than 7.45, you have an alkalosis. Now, how do you know if the cause is bicarbonate ion, so metabolic, or carbon dioxide, so respiratory? Well, if there was a metabolic alkalosis due to the levels of alkaline bicarbonate ions being high, then we would expect to see a compensatory increase in the more acidic carbon dioxide. However, if there was a respiratory alkalosis, then we would expect to see a decrease in the levels of acidic carbon dioxide and a compensatory decrease as well in the more alkaline bicarbonate ions. I should also note that metabolic compensation for respiratory acidemia or alkalemia takes a lot longer than respiratory compensation for metabolic acidemia or alkalemia. Okay, let's move on to part 2. What was the mechanism of action of the drug she was most likely taking for her idiopathic intracranial hypertension? A. An ACE inhibitor. B. A beta blocker. C. A calcium channel blocker. D. A carbonic anhydrase inhibitor. Or E. A potassium-sparing diuretic. Now you just have to know this one. A treatment for idiopathic intracranial hypertension is acetazolamide, which is a carbonic anhydrase inhibitor. Now it's thought that inhibition of this enzyme in the choroid plexus found in the meninges that surround the brain reduces the amount of CSF being produced and so reduces intracranial hypertension. Now carbonic anhydrase also acts in the kidneys, where it facilitates reabsorption of bicarbonate ion from the proximal tubules of the nephron. Inhibiting this action with acetazolamide therefore would result in a decrease in this reabsorption of bicarbonate ion, hence the lower pH and metabolic acidosis. Now let's go on to part 3. She tells you that she was also taking medication for her acne. Which drug was she taking that most likely precipitated her idiopathic intracranial hypertension? A. Acetazolamide, B. Dapagliflozin, C. Tetracycline, D. Carbamazepine, or E. Vancomycin. Now again, you just have to know this one. The correct answer is C. Tetracycline, the only drug on this list that is currently recommended for acne treatment and a side effect of which, albeit rare, is intracranial hypertension. Acetazolamide is a carbonic anhydrase inhibitor, as we've just discussed, used to treat idiopathic intracranial hypertension, not precipitate it. Dapagliflozin is an SGLT2 inhibitor used in the management of diabetes. Carbamazepine is an antiepileptic, and vancomycin is also an antibiotic like tetracycline, but not used in the treatment of acne. Okay, anyway, that is all for this video. Thank you so much for watching. If you found it useful, please do give it a big thumbs up down below, just so I know that this is worth spending my time on. If you want to see more SBA videos, check out my playlist right here. If you're interested in learning more about research or my PhD, or academic rambles in general, then please do check out my latest video up there. And if you want to follow along with what I'm doing here, then please do hit that subscribe button over there. Alright, I will see you guys next time. Bye for now!